So hi guys, after so many days we are again back on a very important topic, which is maternal pelvis. Okay, so why this video is important? Because this is a wholesome video which will be applicable for UG students, PG students, nursing students, or anyone preparing for an entrance exam, or anyone practicing obs and gyne who should know maternal pelvis and fetal skull. So yeah, this is one very important topic together, maternal pelvis and fetal skull, but I am taking it in details, so you can learn from here both for theory and your practical purpose. Even you can write a notes from here also. I have put this in details after reading from many important books like Williams and Datta and few other books. So please listen to the video very carefully, and it will be better if you can watch this video by having the maternal pelvis by your side. So it will be better for you to understand. This is a very important as well as very confusing topic also. So try to have maternal pelvis along with you. You can watch this video along with your friends in a class, so that you can get access to the maternal pelvis model. So let's begin. First is basic anatomy. So this is maternal pelvis, and it is a bony ring like structure which is formed by two hip bones. Okay, so this is one hip bone, this is another hip bone, and this hip bones again has three parts, as you know from your anatomy class: ilium, ischium and pubis. Okay, so the ring is formed by two hip bones, one sacrum and one coccyx. Okay, and these are joined by four joints, two sacroiliac joints. These are two joints. Okay, so by these two joints, two sacroiliac joints and one sacrococcygeal joint and one pubic symphysis, this joint. And again the pelvis is divided into two parts, false pelvis and true pelvis. So true pelvis, which is again formed by the bones, and false pelvis, which is just above the true pelvis. Now what are the boundaries of false pelvis? So imagine above the bone, what are the structures lying above this bony ring? Posteriorly, lumbar vertebrae, obviously there is that vertebral column, so lumbar vertebra posteriorly. Anteriorly there is anterior abdominal wall, and laterally there is iliac fossa. Okay, so biiliac fossa. And the only function of false pelvis is to support the pregnant uterus, otherwise it has no function in gynae patients. And now true pelvis, it forms the birth canal of the mother. It is shallow in front, as you can see. Okay, in front only this is the part, otherwise in back this is the part of the pelvis. So it is shallow in front, and it is formed by pubic symphysis in front. There was pubic symphysis in front, and it measures 4 centimeter. Okay, so there was two bones, two pelvic bones, and there is one sacrum and coccyx, and in front there is pubic symphysis. So the measurement of the anterior part of the front part is 4 centimeter, and it is deep posteriorly because it is formed by sacrum and the coccyx, and the measurement is 11.5 centimeter. Okay, so it is shallow in front and it is wide in back. So we divide the pelvis into inlet, cavity and outlet. Now you know how bony pelvis is formed, what are the bones and the joints forming it, and what is true pelvis and false pelvis. False pelvic ka function is to support the pregnant uterus, and the true pelvis forms the birth canal. Okay, now the pelvis is divided into three parts, in three structures: inlet, cavity and the outlet. And the different, how do we know about the diameters of the inlet, cavity and the outlet? You cannot measure it in a living person, right? So by your hands or by any clinical method. So what do we do? How it has been measured? So X-ray was taken and CT was taken, and that is how we know the diameter, that this is the standard diameters of the pelvis. And what we do in labor is clinical pelvimetry. What like we cannot measure all the diameters, we can only measure one AP diameter, which I'll tell you later, and that is known as clinical pelvimetry. Along with the AP diameter, we see some of the structures around to see if the pelvis can accommodate the baby during its process of delivery, and then we comment if the pelvis is adequate for that baby or not. Okay, so we'll learn it now. Pelvic brim, pelvic inlet, the part of the pelvis which is letting the baby to be inside the birth canal is the pelvic inlet, and this is formed by this brim. Okay, and this is one very important viva question, like for UG students, if you are answering very well, this question may be asked to you, and for PG students this is very common question and this is very much expected out of you. Okay, this is must know answer for a PG student. So what are the parts forming the pelvic brim? It is numbered from 1 to 9. Number 1 is upper border of symphysis pubis. This you can see. Okay, so this is the upper border of pubic symphysis. This is number 1. Then pubic crest, number 2. Then there is one pubic tubercle, number 3. Then pectineal line. Okay, then iliopubic eminence, then iliopectineal line, then sacroiliac articulation, this part, then anterior border of the ala of the sacrum, 8, and then sacral promontory, 9. So you should remember this in order from front to back. So this is from front to back. Okay, this is very important, very important portion of this topic. Now pelvic inlet. So you know the anatomical position of the pelvis. It is not horizontal, it is tilted like this. First, what is the shape of the pelvis? It is, most of the pelvis are gynecoid in shape. I'll tell you different shapes of the pelvis later, but just remember for the time being that the most common shape is gynecoid, with the AP diameter being the shortest. Okay, so in this gynecoid type of pelvis, AP diameter is shortest, and in some other kinds of pelvis transverse diameter is shorter, or oblique diameter and so on. Just remember most common is gynecoid, where AP diameter is shortest. And what is the plane? The plane of the inlet is imaginary flat surface bounded by the bony points of the brim, as I have just told you a little while earlier, that this is the plane, imaginary plane, which is bounded by these boundaries of pelvic brim. Okay, and what is the inclination? It is 55 degree to the horizontal. Just remember this number. And the angle between the plane of the inlet and the fifth vertebra is 135 degree. Just remember these two numbers, these are very important. Okay, the angle of inclination and this angle between the lumbar vertebra and the plane, it is 135 degree. Now how will it affect the function if the angle of inclination is higher or lower? So high inclination means this angle will increase like this. Okay, this will increase like this. So high inclination. How does it matter? If the angle is increased, which is commonly seen in sacralization of fifth lumbar vertebra, means lumbar vertebra is here, it is more vertical, and sacral is like more oblique. So if lumbar vertebra becomes oblique, so the angle of inclination will increase, and it will result in all these things: delayed engagement of the fetal skull, fetus head, because the uterine axis does not align with the pelvic inlet. So in order to function correctly, the axis of the uterus should incline with the axis of the inlet. Okay, but in case of high inclination, there is malalignment which will result in delay engagement of the fetal head. Again, there is increased likelihood of OP position. OP means occipito-posterior position. There will be difficulty in descent due to relatively longer birth canal. Obviously, if the angle of inclination is high, the birth canal will be longer. So there will be delay in delivery, and there will be a flat sacrum which interferes with proper internal rotation of the fetal head. Okay, and what if there is low inclination, means lumbarization of the first sacral vertebra? Then what will happen? The angle of inclination will be lower, but there is not much significance of this, except it may facilitate early engagement of the fetal head. Okay, so again, that was one important topic. Whatever I am teaching you slide by slide, it is like one short note in itself. Maternal pelvis is a very vast topic. I have tried to bring all these theory parts also together in this PPT, so that you can be benefited from here, both for your practical and theory aspect. Now we are talking about pelvic inlet. So we talked about the boundaries of the pelvic inlet: imaginary plane, inclination, high inclination, low inclination. Now AP diameters of the pelvic inlet. So what did I told you? Pelvic inlet, there will be AP diameter, there will be oblique diameter, there will be transverse diameter. Now the AP diameters are three: true conjugate, which is also known as anatomical conjugate, obstetric conjugate, and diagonal conjugate. Okay, so this is true conjugate. It is from the midpoint of the upper border of pubic symphysis to the upper border of first sacral vertebra, and it is 11 centimeter. Okay, and the importance is only anatomical, and you cannot measure it. Okay, next, the second one is obstetric. It is from the the most distal point of the pubic symphysis to the upper border of the first sacral vertebra. Again, it is 10 centimeter. You cannot measure. It is shortest, but it is very important. Now the third one is from the lower border of the pubic symphysis to the upper border of first sacral vertebra. Now you can measure it, because when you do per vaginum examination, you will do digital examination from this point. So this you can measure this point. Sorry. Yeah. So you can measure this point, and you can measure this point by your fingers. So this is measurable, and this is 12 centimeter. So just remember 11, 10, 12 centimeter. And why obstetric conjugate is most important? Because it is the shortest AP diameter of the pelvic inlet. It is the most important diameter for engagement of fetal head, and the important key point is it cannot be measured directly. Now, how will you measure the diagonal conjugate? This also comes as a question, very important viva question. Okay, so if you are answering well, this may be asked from you. So you see, we were doing the per vaginum examination. With your finger, you try to palpate the sacral promontory, and you mark the point on your on your hand till when there is this point, the lower point of pubic symphysis, and then you bring it out, and then you measure it in centimeter and whatsoever. So I have just written steps by steps, so it is easier for you to answer. So you place the patient in dorsal position, and then you insert middle and index finger into the vagina. Then you follow the curvature of the sacrum, and then you try to reach the sacral promontory. So if a pelvis is adequate, you won't be able to reach, but if a pelvis is short or inadequate, you will be able to reach. Okay, so you try to reach the distant point as much as possible. Identify the promontory where the bone recedes from the finger. Mark the point where the lower border of the pubic symphysis touches the examining hand using the other hand or by any marker. and then you withdraw and measure from the tip to this, that is the diagonal conjugate practical point. If the promontory cannot be reached or it is reached with difficulty, then the pelvic inlet is adequate for vaginal delivery. So what I told you earlier. Now transverse diameter of the pelvic inlet. I have told you about antero-posterior diameter 3, true conjugate, which is also known as anatomical conjugate, obstetric conjugate, which is most important but cannot be measured, and that is the shortest also, and then the diagonal conjugate, which we can measure. Now about the transverse diameter of the pelvic inlet. So these are the transverse diameter of the pelvic inlet, which you can see. It is the distance between two farthest point on the pelvic brim along the iliopectineal line, which is 13 cm. So AP diameter were true conjugate, which was 11 cm, obs conjugate, which was 10 cm, and diagonal conjugate, which was 12 cm. And now the transverse diameter is 13 cm, and it divides the pelvic inlet into anterior and posterior segment. You can see it. What is the importance of this transverse diameter? So there is one concept called obstetric transverse diameter, which bisects this inlet into two equal parts. Okay, and this is the functional diameter through which the fetal head engages. This is the importance, and it is equal to or slightly less than the anatomical. This is the anatomical transverse diameter. Now the oblique diameter of the pelvic inlet. So you have learned about the anterior, antero-posterior, transverse, and now the oblique. So there is right oblique diameter and left oblique diameter. From which points you measure this? From one sacroiliac joint to opposite iliopubic eminence, and this is 12 cm. Okay, and it is named according to the sacroiliac joint. So if you are taking the right sacroiliac joint and the left iliopubic eminence, the diameter will be called as right oblique diameter, depending on which side sacroiliac joint ka point you are taking. Now sacrocotyloid diameter, from the middle point of the sacral promontory to the iliopubic eminence. This is sacrocotyloid diameter. Okay, this is 9.5 cm. What is the clinical importance of the oblique diameter? So it represents the space available for biparietal diameter of the fetal head, and in flat pelvis head engages through this diameter only. Okay, now cavity. You have learnt about AP diameter, oblique diameter, and transverse diameters, and now come to the cavity of the pelvis. So inlet is done, boundaries are done, plane are done, your angle of inclination done, different diameters done, and their relative importance done. Now come to the cavity of the pelvis. Okay, I know this is a very boring topic, but this is very important. You should just read it once and then keep revising, otherwise you will forget for sure. Now cavity of the pelvis. So this is this part. This is the cavity of the pelvis through which the fetus will pass through, during its birth process. So the part of the pelvis between the inlet and the plane of least pelvic diameter below is the cavity of the pelvis. I will tell you about the plane of least pelvic diameter. First, know the shape. Again, whatever part you are reading, you should know the shape. Like for plane also, plane of inlet also, I told you the shape is gynecoid mostly. So here the shape is almost round, and this is the most roomy part of the pelvis. What is the plane of the cavity, which is also known as plane of greatest pelvic dimension? This is very, very important. You should know plane of greatest pelvic dimension. Okay. Now from where to where this is? It extends from the midpoint of posterior surface of pubic symphysis. So this is pubic symphysis. I will use a different color. So this is plane of this pubic symphysis. From its midpoint you go to the junction of S2 and S3. So this is S1, this is S2, this is S3. So this junction. So this is the plane of greatest pelvic dimension, as you can know from the name, greatest pelvic dimension means it is the most widest part of the cavity. Okay, and the axis of the cavity, it is perpendicular to the plane of the cavity, that is like this. Okay, so shape, axis, plane done. Now diameter, again AP diameter, transverse diameter. AP diameter is 12 centimeter, again from the midpoint of this posterior surface to the junction of S2 and S3, and transverse diameter is 12 centimeter, but it is not precisely measurable, obviously, because there are muscles, nerves, vessels, fats and other tissues. Now what is obstetric outlet? This is also again very important topic. Cavity is done, now come to outlet. So we did inlet and we did cavity, now come to outlet. Okay, so the segment of the pelvis bounded above by the plane of least pelvic dimension and below by the anatomical outlet is called the obstetric outlet. I'll tell you what is anatomical outlet also. So boundaries, anterior wall is deficient in the pubic arch, there is no pubic arch, and the lateral walls are formed by the ischial bone. You can imagine, or if you have pelvis along with you, you can see laterally there are ischial bones, and the posterior wall includes the whole of coccyx. So this is coccyx. Okay, so this is obstetrical outlet. The plane is otherwise known as plane of least pelvic dimension or narrow pelvic plane. So which is the plane of least pelvic dimension? It extends from the lower border of the pubic symphysis, from this lower border of pubic symphysis to the tip of the ischial spine. To the tip of the ischial spine is in the lateral side, on both sides ischial spine, and posteriorly meet the tip of fifth sacral vertebra. So this is the plane of least pelvic dimension. Transverse diameter is bispinous diameter, again between ischial spines, between two ischial spines. This is 10 to 10.5 diameter. Why this is called the plane of least pelvic dimension and why it is very important? One of the most important significance is if a fetal head can pass through this diameter, then the birth is likely, vaginal birth is likely. But if a fetal head is unable to pass through this diameter, then there will be obstructed labor or CPD or prolonged and delayed labor. So that is why you should know this plane. Anterior diameter is 11 centimeter. It extends from the inferior border of the pubic symphysis to the tip of sacrum or coccyx. Posterior sagittal diameter between the tip of the sacrum and the midpoint of bispinous diameter. Again, if this is ischial spine, this is bispinous diameter, and this is sacrum. So from the tip of the sacrum to the midpoint of the bispinous diameter. So from the tip of the sacrum to the midpoint of the bispinous diameter, if this is ischial spine, that is posterior sagittal diameter, which is 5 centimeter again, and the axis is by a line joining the center of the plane, as you can imagine, of the sacral promontory. Direction is almost vertical. Now what is anatomical outlet? It is also known as bony outlet, as it is formed by bone. So just look at the pelvis or imagine. Okay, in front it is formed by the lower border of the pubic symphysis again, and laterally there is istiopubic ramus, ischial tuberosity and sacrotuberous ligament. Just remember this two. And posteriorly there is tip of coccyx. So this is bony outlet. Why? Because the plane is formed by bony points. And there is two, just imagine these two triangular planes are there with a common base from one ischial tuberosity to another ischial tuberosity, and the apex of the anterior triangle is formed by the inferior border of the pubic arch, and that of the posterior triangle is formed by the tip of the coccyx. Okay, and the angulation is 10 degree with the horizontal. and the axis is again perpendicular to the plane of outlet. Just few more slides, so just bear down with me and complete this topic. I know this is getting very boring, but this is very important topic. At least just take the notes. I have put in a lot of efforts for making this PPT, and just listen, try to get at least something from this video into your mind, and just get done with this topic. Why you want to keep this boring and these very much volatile topics for the end? You should finish those topics first which are your weaknesses or which you fear the most, and just be done with it. So just get done with it. Again, you have to know the diameter: AP diameter, transverse diameter, posterior sagittal diameter. Now the subpubic angle, it is very important. Obviously, subpubic angle is the angle formed by, as you can see, subpubic angle is the angle formed by the two descending pubic rami. In normal female pelvis, it is 85 degree. Okay, and the pubic arch, it is formed by the descending rami of both sides, and it's of obstetric importance. Normally it measures 6 cm in between the pubic rami as at a level of 2 cm below the apex. So if this is apex and this is 2 cm below the apex, this diameter, this part will be 6 cm according to them. Okay, and you can assess it by placing your 3 fingers below the pubic arch. Now again, a very very important topic: waist space of Morris. So what is the waist space of Morris? Just imagine when the fetal head is coming out of vagina, so it is coming through below the pubic arch, and the fetal head is obviously, it is round, if not almost round. So it will come like this, and there will be some waist space between the pubic arch and the fetal head. Okay, and narrower the pubic arch, the more is the fetal head displaced backwards, and the lace room will be available for it. Okay, so if this narrow, so obviously it will be displaced backward only. It will be difficulty for the head. It will be difficult for the head to come forward, and the room available will also be less for the fetus. Now, normally the subpubic arch is rounded in a adequate female pelvis, and lace space is wasted. So imagine if you place a round disc of 9.3 cm, which is equivalent to the biparietal diameter of a well flexed fetal head, which is almost 9.5 cm. And when you place this below the pubic arch, the distance between the pubic symphysis and the circumference of the disc, that is this distance, is normally not exceeding 1 centimeter. Okay, this distance is less than 1 centimeter, and this measurement is waist space of Morris, and this should not exceed more than 1 centimeter. And what do we call the available AP diameter? When this waist space of Morris is more than 1 centimeter, the AP diameter of the outlet extends below the pubic symphysis. Just imagine. Okay, just imagine. And on the pubic rami for a distance equivalent to the waist space of Morris. And the distance between the set point and the tip of the sacrum is also called available AP diameter of the outlet. It is through this diameter that the head escapes out of the bony pelvis. Now mid pelvis. So I have taken this as a separate slide because this is important. What is mid pelvis? This is the plane of greatest pelvic diameter, and below this is the plane of mid pelvic plane. So mid pelvic plane again extends from the lower margin laterally to the ischial spine, and then the junction of S4 and S5. This is S4 and S5, this plane. Okay, mid pelvic plane or tip of the sacrum depending on the configuration of the sacrum. If the plane meets the tip of the fifth sacrum, then it coincides with the plane of least pelvic dimension. So again, this is plane of greatest pelvic dimension, this is mid pelvic plane, and this is plane of least pelvic dimension. Okay, one plane, two plane, three planes. Again, very important part, significance of plane of least pelvic dimension. These may come as a short notes and you have to write almost all of these points. Narrowest plane corresponds to the origin of levator and eye. In this plane there is internal rotation of the fetal head during delivery. There is beginning of the forward curve of the pelvis axis. I will tell you about the pelvis axis, just remember for the timing. It is at this plane that the curve which is coming backward now turns forward. It is a landmark for pudendal nerve block. We call station 0 while assessing the Bishop score doing per vaginal examination in a laboring patient. We comment on the station if it is 0, where the fetal head is, at what station. Then we say station 0, it means the plane of least pelvic dimension, and it is irregularly oval and notched on its side by the ischial spine. Again, pelvic axis. So you see, through the inlet, through the cavity, it is coming like this, vertically and backward. But now from here, after the plane of least pelvic dimension, it will come down and forward. So if you make a curve, it will become like this, which is known as anatomical curve of Caras. So it is formed by the axis of the obviously inlet, cavity and outlet, and it fits with the concavity of the sacrum. The fetus does not, however, traverse the uniform curve path, obviously. And what is the obstetrical axis? Obstetrical axis is through which the fetus negotiates. So fetus negotiates like this. It is not uniformly curved. Direction is first downward and backward up to the level of ischial spine, and then forwards from the ischial spine. Okay, I told you about pelvic joint. So symphysis pubis, sacroiliac articulation, sacroiliac joint. Just read it once. And there is physiological enlargement of pelvis during pregnancy and labor. How? Because imaging studies have shown there is an increase in weight and mobility of the pubis symphysis. It is synovial joint, so it will move, okay, to and fro during labor. The pubic bone may separate by 5 to 10 mm, so it is quite, there is gliding movement of symphysis pubis near term. Similar changes occur in sacroiliac joints, and there is relaxation of pelvic joints due to progesterone and relaxin hormones. There is increase in epidiameter due to rotatory movement of the sacroiliac joints, and in lithotomy position the epidiameter may be increased by this much. This is very important. And the coccyx is pushed backwards when the head descends to the perineum. So these are the points which you should remember, that what happens to the pelvis during labor, how the pelvis become more roomy for the baby to to let the baby come out through the vagina. Now, what is the role of the pelvis in labor? In labor there are 3 important parts. One is pelvis, which is also known as passage. One is power, which is uterine contraction, and one is passenger, that is fetus. So pelvis passage forms one of the 3 important pillars of vaginal delivery. So if it is inadequate, it will lead to cephalopelvic disproportion. Baby is bigger and pelvis is smaller, so CPD, and it will result in prolonged and obstructed labor. So this is the rough diameters: epidiameter, oblique diameter and transverse diameter. The cavity, I told you, cavity is almost same all the diameters, so it is round. In the outlet epidiameter is more than the transverse, and in the inlet obviously transverse diameter is more than the AP. I have made it in table. This is very important. So if you are unable to understand, just watch the video twice or thrice, and still if you are able not able to understand the topic, just mug up the diameter. You have to remember some diameters, at least these diameters. These diameters, there is no other way. Sorry, I cannot help much more than this. You have to remember. And again, this is to MBBS level question, very important MBBS level question, and this is a must know question for PG. Types of female bony pelvis: gynecoid, anthropoid, android, and platypelloid. Gynecoid is most common. The shape of inlet is round, here AP, here triangular, here transverse. In the mid cavity is divergent, side walls are divergent, and ischial spine. Okay, IS is ischial spine. It is not prominent. Here it is prominent, and the side walls are convergent, are straight or divergent. Here it is convergent, and ischial spine is prominent. Here the walls are divergent, and ischial spine is not prominent. The shape is like this, platypelloid. Okay, android is like heart shape, so mostly it is like this. In anthropoid it is oval shaped, and gynecoid is mostly round. Okay, so this is how it is. Just remember, this is more common and this is least common. Here the subpubic angle is wide, quite wide, and obviously in platypelloid it will be very wide, and it is narrower in anthropoid and android. Here delivery is favorable, here it becomes OP position, here delivery is very difficult, and here engagement is difficult because of shorter AP diameter. Now these are the few rapid questions. Narrowest part is interspinous diameter, that is plane of least pelvic diameter. Most important diameter for engagement is obstetric conjugate, which I told you, which is 10 centimeter. So you measure the diagonal conjugate and then you subtract 1.5 to 2 centimeter from that, and that will give you the obstetric conjugate. Measured clinically is diagonal conjugate. Best pelvis is gynecoid because it is favorable for normal delivery, normal vaginal delivery, and the most common pelvis in male is android. Station 0 indicates ischial spine. Pelvis type for normal delivery is gynecoid, and OP position is most common is anthropoid. So these are some MCQ type questions which examiner may ask you. So thanks for watching. Again I'll say, okay, watching video is helpful, but if you have maternal pelvis in your hands and you can correlate this theory with the pelvis, it will be very helpful for you. So get a pelvis model and just learn it alongside the model. So thanks for watching the video. If you have any doubt, you can ask me in the comment section. I know this is a very boring topic and this is a very volatile topic, but there are few things which are very important. First, I told you about the boundaries of the pelvic inlet, that is pelvic brim, that is very important. Then you should know how to measure diagonal conjugate. You should know planes of greatest pelvic dimension, least pelvic dimension, and the importance of the plane of least pelvic dimension. You should know about the curve of Carus, waist space of Morris, types of female bony pelvis, you should be knowing, and these MCQ questions. Okay, so just keep learning and keep watching. Thank you.